Primary Care Perspectives on Obesity, Embracing Novel Agents to Optimize Patient Outcomes. Hello, I'm Dr. Robert Kushner. I'm a professor in the departments of medicine and medical education at the Northwestern Feinberg School of Medicine, as well as director for the Center of Lifestyle Medicine at Northwestern Medicine in Chicago. For accreditation, the AAFP has reviewed primary care perspectives on obesity, embracing novel agents to optimize patient outcomes, and deemed it acceptable for up to one live AAFP elective credits. Term of approval is from 12/22 to 12/23. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Physicians can also earn one AMA PRA Category 1 credit. To obtain credit, please complete post-test and evaluation. These are my faculty disclosures, and they can also be found on the course page. The learning objectives are as follows: to review the etiology and epidemiology of obesity, to appraise currently FDA-approved medications for obesity, take a deeper dive into two of the newest approvals for GLP-1 agonists, and more so, a trial data evaluating the GLP-1 GIP agonism regarding one of these medications. And lastly, we're going to do a lot of real-world case-based scenarios to formulate patient-centric treatment plans. I think you'll find those particularly helpful to think about your own patients and how you would manage patients in your clinic. So let's get started. Let's start off with laying the foundation in obesity management, etiology, epidemiology, and the urgent need for change. Let me start off with a question regarding epidemiology. 41.9% of US adults suffer from obesity. That's a BMI of 30 or more. What percentage of US adults are predicted to suffer from obesity by 2030? 65%, 59%, 49%, or 37%? Well, the answer is actually almost 50%. It is estimated by modeling that nearly 1 in 2 adults will have obesity, or nearly 1 in 4 adults is projected to have severe obesity. That's a BMI of over 40. Severe obesity is likely to become the most common BMI category among women, over about 28%, non-Hispanic Black women, 32%, low-income adults. So this is a serious problem. If you're not currently engaged in the management of patients who present to you who have obesity, this is the time to do so, because it's projected to get even worse, and it's the most common non-communicable disease worldwide. So it's a very timely conference webinar for you to participate in. So as a backdrop, how do we think about obesity? It's very important to think of it as a chronic relapsing disease. It is not a condition that we can cure or be fixed. It's not like a rash or an earache or some kind of infection. We need chronic management, just like we think about in diabetes or asthma or hypertension. So for many, it's really a paradigm shift that this is something we need to get engaged in long term. So again, diabetes is probably the best comparator I could think of. We all have familiarity with that. We never think we see a patient for diabetes for one visit. We give them recommendations. We send them on their way and have them come back in 6 months or a year later. No, we think about chronic ongoing management to help patients manage their diabetes better. So it's exactly the same as that. That's the kind of connection I want you to have. It's long-term care and management. It's guiding a patient towards changes they don't know what to do, and providing multiple layers of intervention, always a foundation of lifestyle management, diet, physical activity, and behavior change, again, just like diabetes. But then also think about potentially more aggressive approaches if lifestyle alone is not effective, again, just like diabetes. In that case, we would think about using metformin and some of the newer agents. In obesity, we want to think about using anti-obesity medications or medications or chronic weight management. And we're going to talk a lot about that in this presentation to bring you up to speed on what are the medications and how should we start thinking about using them. So another kind of general epidemiology, etiology question: what factors contribute to obesity? genetics, epigenetics, which is including the perinatal period of program development, socioeconomic status, access to available of nutritious foods, iatrogenic causes, such as using insulin, sulfonylureas, steroids, psychotropic medications, emotional health and stress, and sleep disturbance. So it's kind of set up as a question for you. And you know what? The answer is all of the above. It's a multiple, complex, multifactorial disease is the way we think about it. So it isn't as simple, oh, I've seen one patient with obesity, therefore I know why you also suffer from obesity. Everyone comes in with their own story, their own journey, their own determinants of what makes it hard to lose weight and factors that cause them to gain weight in the beginning. So by taking a detailed obesity-related history and understanding which of the factors listed here, among many others, are important in that particular patient, you're going to be able to help them more effectively. So I do want to shift gears with this kind of quick background to novel approaches and novel outcomes regarding treating obesity. So statement to be aware of is that pharmacotherapy or anti-obesity medications helps patients overcome the adaptive response to weight loss, adhere to a healthy lifestyle, and frequently has metabolic health benefits beyond weight loss. So let me unpack that a little bit more. Medications work biologically, almost always up in the brain, different structures in the brain, to deal with the energy and appetite dysregulation that many patients with obesity have. Things like inappropriate hunger cues, fullness cues, over enticement of food, cravings, thoughts of food. Those are the problems that occur with obesity. And these medications help regulate that so they control appetite. And by doing so, individuals are able to adhere to a healthier calorie-reduced diet with more resolve and more control. And they also deal with the oftentimes reemergence of the weight or weight recurrence that occurs with lifestyle alone by continuing to work biologically on this appetite regulation. So that's how medications work. They affect appetite, which then allows patients to translate those changes in appetite to improving their diet. And it's the reduced caloric diet and healthy diet that causes people to lose weight. Now, despite the strong evidence supporting all these benefits, interestingly, only 2 or 3% of adults in the United States who are candidates for medication actually receive a medication. So it's left, the slide is left as a why, and that's for you to think about, although I'll give you my own feelings. You may want to think about, if you don't use anti-obesity medications often or when indicated, why is that? Well, part of it, I think, is lack of education, lack of awareness, stigma, which is the title of this slide, the bad rap the medications have had, the legacy effect of other medications that have been taken off the market, and also, I think, our own stigma often with patients with obesity, our innate, our historical feelings of they ought to be able to lose weight. If they tried harder, push themselves away from the table, move more, take better care of yourself, your weight would be under better control. Those are old myths and misunderstandings. So if we move forward and understand the biology of obesity and how these medications work, we ought to be thinking about using medications more often and increase the number of patients who are actually getting the benefit from them. Now, typically monotherapy combined with lifestyle changes leads to a wide range of weight loss. We always think of weight loss as a percentage of weight loss, and ranges widely from 3 to 5% all the way to 22% of one's initial body weight. It's a wide range, and you're likely to see that in your own practice when you see the heterogeneity of response. So how does that compare to bariatric surgery or lifestyle alone? Well, at one end, we have lifestyle alone, which on average causes anywhere from a 3 to 5, maybe 8% weight loss after 1 year. Without much intervention or resources, people lose about 3% body weight alone. You can get it up to 8% if you actually give a lot of resources. At the other end of the spectrum is bariatric surgery, which often leads to a 25 to 30% weight loss after 12 to 18 months. So we now think about medication as filling that gap between lifestyle alone, which is the low end, and bariatric surgery, which is at the high end. With the evolution of more emerging effective medications, we're actually closing that gap even closer and getting closer to bariatric surgery, but we're not really quite there yet, particularly in the long term. So the general guidelines as far as using medications is that pharmacotherapy and or bariatric surgery should be used adjunctively with lifestyle therapy in patients who are overweight with medical complications or obesity, either after failure of lifestyle therapy, which I actually don't like too much, or concurrently with patients with weight-related complications. The reason I don't like this whole idea of failure is we should never be in a position where patients have to earn the right for us to prescribe a medication. And that's what failure kind of alludes to. Like you have to fail doing it on your own before I give you a medication. And again, think of diabetes as the comparator. We would never ask patients with diabetes to prove us that they have failed lifestyle alone before we would give a medication for diabetes. That's not how we think, right? We are aggressive in treating diabetes, even pre-diabetes these days. So obesity is unfair to have patients prove that they have failed lifestyle alone to think about medication. We need to think about that much earlier. In 2022, the American Society of Metabolic and Bariatric Surgery, along with international colleagues, updated the indications for bariatric surgery and actually recommended we think about it at a much lower BMI, even as low as 30 in a patient with diabetes. So becoming more aggressive with our patients is very, very important. And we need to think about it earlier, not later. Now let's go into the office itself. So how do we interact with patients? How do we frame our conversations about obesity? That's where the 5 A's come in. I don't know how many of you are familiar with this, but the 5 A's were originally developed for treatment of smoking cessation and then later adapted for treatment of individuals with alcohol misuse. We also use the 5 A's. It's very handy, I think, in treating when thinking about obesity. But we changed the first A, as many of you may have learned it, which is usually assess. For obesity, we changed the first A to stand for ask. And it's very important for obesity because broaching the topic in an empathetic and sensitive and understanding way is so important for the stigmatized condition. You could assume patients are seeing you with a whole legacy of other healthcare providers, either shaming them, embarrassing them, being paternalistic in what you ought to do, telling them it's your fault in moral terms and so forth. Many patients have that historical connection when they see you, and they're often wondering, how are you going to broach the topic of weight? And by asking them the first day, I think it is the most reasonable way to do it. And it sounds something like this. Mrs. Jones, is this a good time to talk about your weight? Have you thought about your weight? I've looked at your weight trajectory in my electronic medical record, and it looks like you've been gaining 10 pounds, 15 pounds over the past several years. Is this something you want to have more of a conversation about? Because I think there are options we can provide. So that's what I mean by ask. And once you ask, you then go into the other A's, which is assess the problem like BMI, take a weight history, give advice after you've taken a good history, agree upon mutually shared goals about what you're going to do with diet, activity, behavior, medication, bariatric surgery, and then provide assistance, writing a prescription, referring to a registered dietitian, referring to a commercial weight loss program. So that's what the 5 A's are all about. And if you're not familiar with it, I encourage you to do more reading because it really helps you and learners like medical students and residents how to frame a conversation with someone with a chronic relapsing disease. In this case, of course, we're talking about obesity. So this is one of several cases I want to go over to really highlight and emphasize the importance of decision-making in the office. So I'll read the question and then have you think about what the next steps are. So for case 1, we have a 53-year-old woman, a female, who presents to the office for obesity management. She has struggled with her weight for 30 years, having followed multiple diets and exercise programs without long-lasting results. Her primary care doctor has recommended a low-calorie diet and regular exercise for the past 10 years. She is seeing a nutritionist and working with a personal trainer. Blood pressure is 152/90, not well controlled. BMI is 43. Medical history includes well-controlled type 2 diabetes, hypertension that's not well controlled, as I just said, hyperlipidemia, sleep apnea, arthritis, and seasonal allergies. Her medications include insulin glargine, insulin lispro, glipizide, metoprolol, atorvastatin, and diphenhydramine for allergies. After you ask about her personal motivations and goals for weight loss, you learn that she is highly motivated to follow a plan that actually works. So what advice would you give the patient at this time? Lifestyle counseling and a referral, discontinue and replace obesogenic medications, offer anti-obesity medications, or offer bariatric surgery? Well, the answer from my point of view is all except A. I can't see doing again. She's already been doing that for 10 years. Why in the world would you give the exact same advice when it's not working for the past 10 years? So I would cross that one out. If you answered B, D, or E, excuse me, if you answered B, C, or D, I think that it's any one of those is potentially reasonable. Picking up on obesogenic medications is very, very important. In this particular case, she is on at least 3 medications that's causing weight gain. And if you can make the change, it's worthwhile. She's on 2 types of insulin, both causing weight gain. She's on a beta blocker, which can cause weight gain. And she's on an antihistamine that can cause weight gain. So I would take a thorough view of those medications and potentially change them. Offer anti-obesity medication? Absolutely. And the one that I would be thinking about actually is an incretin hormone, which we're going to talk about much more in a moment, and even bariatric surgery. She may not be ready for that, but she says, I want something that actually works. Bariatric surgery actually works. In fact, it is the most effective evidence-based treatment we have for obesity. So all of them except A is a reasonable answer. So let's take a deeper dive into anti-obesity medications. We have different categories. They're all emerging, but for right now, it's reasonable to think about incretin-based therapies, which currently is semaglutide and liraglutide. Those are the only 2 currently approved for obesity. And then we have a new drug, which is tirzepatide, which is currently approved for diabetes, but will be looked by the FDA for approval of obesity. Second category are stimulants. Those are either phentermine-based, phentermine by itself, or phentermine topiramate. Then we have another drug that's approved for binge eating disorder, lisdexamfetamine. And then we have a category of others, naltrexone, bupropion, orlistat, and metformin. Again, metformin is not approved for obesity, but is often used, particularly in individuals with prediabetes or diabetes, and it has appetite-suppressing effects. So let's take a look at these a little bit more. Let's start with the incretin hormones. So there are 2 incretin hormones, that's GLP-1, glucagon-like peptide 1, and GLP, glucose insulinotropic polypeptide. Incretin hormones are secreted by the GI tract in response to oral glucose. They increase insulin sensitivity in the muscle, and as an incretin hormone, they augment the release of insulin that is proportional to the blood sugar. So the higher the blood sugar, they're released. If blood sugar comes down, it does not augment the release of insulin. And they suppress glucagon, GLP-1 does in particular. There is no significant effect on hypoglycemia. That's very important to know. As incretin hormones, they are insulin responsive to the blood sugar itself, so they're glucose dependent. They do decrease gluconeogenesis by the liver, so it reduces the release of sugar from the liver, and it delays gastric emptying, which in part is why these drugs lead to satiety, in addition to the side effects of the drugs, which could be nausea, potentially even vomiting. But there's also, of course, GLP-1, GIP receptors in the brain that affect the appetite. So We have the three drugs, tirzepatide, only approved for diabetes at first. That's the GLP-1 GIP dual agonist, where semaglutide and liraglutide are GLP-1 receptor agonists or monoagonists. All three of those are also approved for treatment of type 2 diabetes as incretin hormones. Total body weight loss compared to placebo, liraglutide is the weakest of them. We'll talk about that a little bit in a moment, about 4% more weight loss than placebo. Semaglutide, quite significant, over 12% weight loss versus placebo at 1 year. Tirzepatide, even more effective, and it's an 18% difference from placebo in weight loss. That is a significant amount of weight loss that has an effect not only on body weight diabetes, but multiple other complications of obesity. Now, there are GI side effects to be considered, as well as contraindications. They can cause gastrointestinal side effects such as nausea, constipation, potentially vomiting, heartburn. We always have to manage that regarding diet. Can cause pancreatitis, although that has not been seen in the recent trials for semaglutide or tirzepatide. An absolute contraindication is medullary thyroid carcinoma. We have to be careful for that. Anyone with a family history of MTC or medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2 or recent history of pancreatitis, we don't want to use these drugs at all. Now, if I go to the second category called stimulants, it's kind of highlighted mostly by phentermine, which is a sympathomimetic, as well as when phentermine is combined with topiramate, a trade name there is Qsymia. They reduce, again, appetite. They are effective, but not quite as effective as the medications I just talked about. Phentermine, we're talking about a 45% difference from placebo. Phentermine topiramate, 7-11%, and lisdexamfetamine, 5-6%. Now, I want to highlight again that there is a great deal of heterogeneity in response to these medications. I'm giving you averages, but you're all likely to have patients in your clinic who we call super responders, done incredibly well, and then those that don't even reach the average weight loss. So we always have to think of using these drugs individually with our patients. Side effects of these drugs, since they're mainly stimulants, is to have to be careful regarding agitation, arrhythmia. If someone has hyperthyroidism, we're not going to use it because of the stimulation. Dry mouth, constipation are really the two most common side effects. And someone with a recent history of stroke or MI or cardiac arrhythmia, we're not going to be using these medications. Someone with uncontrolled hypertension, we're not going to use these medications. So you're going to use your general fund of knowledge about who would you want to give a stimulant to and who would you not you give it. But they are potentially effective medications depending on patients that you see. And then we have this other category, which is naltrexone and bupropion together. That is called Contrave. Orlistat, it's a lipase inhibitor. Orlistat, by the way, is the only anti-obesity medication that does not work by appetite suppression. It works to reduce by competing with gastric lipase, pancreatic lipase, the breakdown of fat. So you end up passing fat in your stool, and that's how that actually works. It's also the only over-the-counter medication for obesity under the trade name Ally. And then we have metformin, not approved by the FDA for weight loss, but often used in patients with obesity. The amount of weight loss is lower with these medications compared to placebo. Now you're talking about a 3 to 5% difference, but again, you may have super responders. Side effects regarding naltrexone and bupropion, probably the most important thing to keep in mind is naltrexone is an opiate blocker. So anyone on an opiate for pain, you would not give that drug because you would not want to block the opiate. Most common side effect is nausea with that medication. You could also get constipation. For orlistat, it's really all gastrointestinal, loose stools, steatorrhea, oily, spotty stools. You have to be careful with that. And metformin, we're all familiar with, mostly GI discomfort, potentially diarrhea. I want to switch back to the incretin hormones. Those are the ones that, incretin hormones and drugs. Those are the ones that are the newest kids on the block and the ones that you may have less familiarity with, at least for the treatment of obesity. You may be using these already for treatment of diabetes, but maybe not be using for obesity. So it's very important, I think, for you to be aware of what is the study that has shown that, or studies, and what is the outcome. So The STEP trials were the trials for semaglutide in treatment with obesity. There's a series, actually multiple phase 3 double-blind randomized controlled trials. In the STEP 1 trials, the one-on-one review for you today, it included approximately 2,000 individuals globally who had a BMI 30 or more, or 27 or more, with at least one weight-related complication like dysglycemia, elevated blood pressure, or hyperlipidemia. They did not have diabetes in the STEP 1 trial. They did in the STEP 2 trial. I'm not going over that one with you today. And they were then assigned 2-to-1 to semaglutide 2.4 milligrams or placebo. Let me point out here that semaglutide, as I've already said, is already been approved for quite some time for the treatment of diabetes, but generally at a lower dose, either at 1 milligram or more recently in the United States, it's approved up to 2 milligrams. For obesity, it's approved under a different trade name called Wegovy with a different pen apparatus and is administered once a week by a self-administered shot up to 2.4 milligrams, so the dose is even higher. In a STEP 1 trial, getting back to that, the dose was escalated over 16 weeks like you would with diabetes. You start low at 0.25 milligrams, and every month you escalate up to the highest dose. All individuals got lifestyle intervention, and the primary endpoint was % weight loss as well as categorical weight loss. So what I'm going to show you here is the effect on weight loss. I'd encourage all of you to read the trial to understand the implications and benefits across the board for metabolic health, quality of life, and so on. But the one data I'm going to be showing you right here from STEP 1 towards the right is the average weight loss and the tempo of that weight loss over 68 weeks. And what you see quite remarkably is that in a placebo group, they lost a little under 3% of their body weight, getting lifestyle alone, not unexpected. In the semaglutide group, getting up to 2.4 milligrams weekly, on average, they lost 15% of their body weight. You can see the drastic difference between placebo and semaglutide, even though they both got lifestyle alone. Towards the left, what you see is what's called the categorical weight loss. Now, in other words, what % of subjects lost 5% of their body weight, 10%, 15, and 20% of their body weight, and so on. And what you see is that across all these categorical weight losses, many more patients lost weight on semaglutide versus placebo. Remarkably, 1 in 3 individuals roughly lost 20% or more of their body weight. That is actually pretty close to surgical territory, which is quite remarkable. The other randomized controlled trial I want to show you, again, encourage you to all read them yourself, both were in New England Journal, is called the SURMOUNT trial. This is the trial that looks specifically at tirzepatide for treatment of obesity. So again, it was a phase 3 international study, randomized controlled trial, 2,500 individuals, same criteria, BMI 30 or more, 27 or more with at least one weight-related complications. They were randomized to either 3 different doses of tirzepatide, 5, 10, or 15 milligrams, or a placebo, going out to 72 weeks. Dose escalation, the same as you would with any of these incretin hormones, like you did with semaglutide. You start low, in this case, 2.5 milligrams, and every month you escalate up to the dose that each of these cohorts were randomized to. And again, we're looking at % weight loss and categorical weight loss. So similar to the previous data I showed you on semaglutide, towards the right, we're looking at the average weight losses, in this case out to 72 weeks. On the very top, you see placebo. Again, they lost about 2.5–3% of their body weight, just like in the semaglutide STEP trial. But now you see dose response loss in body weight for tirzepatide 5, 10, and 15 milligrams, now losing an average of 22% on the highest dose, compared to 15% with semaglutide. Again, really profound amount of weight loss. And towards the left, you see the actual average data, but in a different graphic form for the tirzepatide 5, 10, and 15 versus placebo. So it's really quite significant. Now, currently, there is no head-to-head trial of tirzepatide with the higher dose of semaglutide. But what the SURPASS trial did do, and these are individuals with diabetes, and you look towards the right, they compared the 3 doses of tirzepatide to semaglutide 1 milligram. That's what we use in diabetes. And you could see the greater weight loss with tirzepatide in individuals with diabetes versus semaglutide 1 milligram. So you can see that comparison there. So we're going to have to stay tuned for head-to-head trials. I don't see them coming soon, but tirzepatide appears independently to be more effective than semaglutide, but both quite effective for patients, not only for diabetes, but also without diabetes. So let's talk about treating patients in the clinic. Let's go back now to a case 2 so we can start to apply some of this information. So here, case 2. We have a 44-year-old male who presents to the office for a wellness visit. His BMI is 28. Medical history includes hyperlipidemia, well-controlled hypertension, but uncontrolled depression. Current medications include hydrochlorothiazide and rosuvastatin. Since his early 20s, he has tried multiple diets and exercise programs without sustained weight loss. He eats small, healthy meals at work, but very large amounts of fatty and sugary foods when he gets home in the evening. He does not exercise. So what would you advise his next steps to be? Lifestyle counseling and referral, discontinue and replace obesogenic medications, offer anti-obesity medications, or offer bariatric surgery. So there's several options here. I see nothing wrong with lifestyle counseling and referral at this point. His BMI is 28. He has a lot of things to work on regarding his large amounts of fatty and sugary foods. He doesn't exercise, never saw a dietitian. I think that would be very, very reasonable. He is not on any anti-obesity medication. So hydrochlorothiazide and rosuvastatin do not cause weight gain, so there's nothing there. Offer an anti-obesity medication? Maybe. He does meet the criteria of having a BMI of over 27 with a complication, which is hypertension. So that possibly you could think about. He does not meet criteria for bariatric surgery. So maybe 2 potential answers there. So let's take the third case. Third case is a 37-year-old female presents to the office for obesity follow-up. Her BMI is 42. She eats a healthy, reduced calorie diet and exercises regularly as per the plan with the nutritionist you referred her to. She was recently taking naltrexone bupropion for a month for weight loss. She did lose 3 pounds in 2 weeks, but experienced significant insomnia and constipation, and it was discontinued. She's not interested in bariatric surgery. So what would you advise her to do? So here we're only going to pick one answer. Add an incretin-based therapy and return to the clinic in 1 month. Advise healthier, low-calorie diet and increase exercise. Reassure, some patients don't tolerate medications or achieve normal BMI, or add lisdexamfetamine and return to the clinic in 2 weeks. What would you do here? Well, I think the best one answer, given what's listed here, is to add an incretin-based therapy and return to the clinic in 1 month. Why? Because it is one of the most effective medications for weight management. As we just talked about, your BMI is 42. She has severe obesity. B, advise a healthier, low-calorie diet. I'm not sure that's going to get her where she needs to be. Reassure her patients don't tolerate the medication to achieve a normal BMI. I don't think that's a great answer. And I wouldn't start lisdexamfetamine. It's not approved for weight loss, and she doesn't have binge eating disorder. So let's go to case 3. Let's continue it. Patient returns the following month and has lost 8 pounds on incretin-based therapy so far, experiencing only occasional mild nausea after some meals. She's still on the lowest dose. Remember, we always start low for both these medications. She's continued to eat healthy and a reduced calorie diet and exercise 3 days a week. So what would you advise for the next steps? You can only choose one answer. 1, stop incretin-based therapy now due to nausea. B, obtain thyroid ultrasound to screen for medullary thyroid cancer. C, advise the patient to mostly eat small meals every few hours, increase the dose of incretin-based therapy, and return to clinic in 1 month. D, advise the patient eat 3 meals per day, but remain on the same dose for another month, given her mild nausea. Well, I think the answer is going to be C. I think it is the right answer. Advise the patient to mostly eat small meals every few hours and increase the dose of therapy in return after that. Eating a healthy, balanced diet, reducing the fat in the diet, not skipping meals, don't overeat is critically important to reduce nausea. If it is effective, you are then going to increase the dose further. You're going to increase the dose based on tolerability, safety, and effectiveness every month after the 4th injection that she gives, and continue to the highest dose that is going to be most effective for her. Not all patients need to reach the highest dose, either for tirzepatide or semaglutide. That's why working closely with your patient is going to be very, very important. So let's finish up. What are the take-home points? Obesity is a chronic disease requiring chronic management. It is not a one and done. It is not a short-term problem that we could find a cure. Again, think just like diabetes. You want to discontinue obesogenic medications when possible. It's one of the first things you want to do is take an inventory, right, of the medications, reconcile those that may be causing weight gain, and when possible, swap them out for drugs that are not causing weight gain. Again, the big culprits would be anti-diabetes medications like insulin sulfonylurea, corticosteroids, potentially beta blockers, psychotropic medications like for schizophrenia or bipolar disorders. Third, counsel qualifying patients on effective anti-obesity medications, bariatric metabolic surgery options. So be proactive. Don't wait for the patients to bring it up to you. We now have very effective and safe medications that we could help our patients who suffer from obesity to be more successful. And lastly, we took a deeper dive into the GLP-1 and GLP-1 GIP dual agonist receptor medications, and they are the future of anti-obesity medications. So jump on board, learn about them, get comfortable, stay tuned. We have more and more effective medications coming up later on. I want to thank you all for your attention, and please complete the evaluation and submit for CE credit.